This is Our Voices, Our Legacies, the Medical College of Wisconsin's Oral History Project. I'm Dick Katchke, MCW's Chief Historian, and today is February 13th of 2017. And today we're talking with Dr. Johnny Hong. Dr. Hong is the Chief of Transplant Surgery, and he is also the Mark B. Adams Professor in the Department of Surgery. Thank you for joining us, Dr. Hong.
My pleasure. Good morning.
Let's start by talking about what led to your interest in going into medicine.
It's a personal experience for me. My dad required a transplant when I was at a young age, and at that time, the transplant that was in the 60s, and at that time there was no transplant capability in the country where I came from, the Philippines, and so he sought the transplant abroad. Fortunately for us, however, for the other patients who did not have that resource, they died. So that sort of hit me hard, that we should be able to provide the cutting-edge medicine locally or in a particular area so that people could access that. You know, just having the experience that cutting-edge medicine is not available at that young age, and as you grow up, it resonated that there's a lot of room that to grow and improve on.
Mm-hmm.
Yeah.
And from that then, so you knew as you planned a career in medicine, transplant surgery was the area that you wanted to go into.
That's right. Initially, as a young child, it's more general. You just want to go and be a physician and hopefully help people. But as you grow, as I grew, the interest in transplant, because of my personal childhood experience, grew stronger and stronger. And why transplant surgery? I think it's one of the few specialties that involve not the surgical aspect of patient care. It actually takes care of the patient in a total comprehensive manner, from their medical condition before transplant, during transplant, and after transplant, to the surgical aspect, and as well as the broad multidisciplinary required, such as immunology, biochemistry, pharmacology. And most of the practice, including mine, is that once you're a transplant patient, I still take care of their general surgical issues. So I don't just do the surgical aspect of transplant, but in general, if they need general surgery like hernia repair, we still take care of those issues.
Now, you went to school in the Philippines then,
Yeah.
And then that was followed by a fellowship, I believe, in Houston.
Yes, I started my after my medical school in the Philippines, I began my surgical training in the Philippines at that time, the only transplant surgical institute in the Philippines, and then moved to Houston, correct.
And why Houston? What was there about Houston?
Well, there are two things. One, my wife was matched there for her training, and two, one of the well-renowned transplant surgeon and immunologist, which became my mentor, and fortunate to have him as a mentor, is Barry D. Cahan. He's a well-renowned transplant surgeon as well as a transplant immunologist.
What were some of the experiences that you had in Houston that helped you grow as a transplant surgeon?
I thought I was fortunate enough to have him as a mentor. And so as a young person entering transplant surgery, I was just surprised that there is a million things that I don't know, and a couple of things. So from the medical aspect, I think, as I mentioned to you, it's the surgical aspect, the immunologic aspect, and then the process of how our body reacts to a new organ. And secondly is what is the metabolic injury that occurred when an organ is removed from a blood supply from the original donor to preserve in cold temperature, and then subjected and exposed to the warm blood of the new individual. So those are a lot of things that I've learned. And what do we do to prevent that body rejecting the new organ and have them recognize that, that new organ there to help rather than to hurt them? So so that's the medical aspect. From the other aspects are, it taught me how to respect our donors, both cadaveric or deceased donor and live donors. I think it's an amazing thing that we're able to help other people, and people are willing to sign up to donate organs once they're declared brain dead, or even before if they don't have any hope in recovery from their devastating neurologic, they would want to help other people.
From Houston, you went then to UCLA,
Yeah.
which is one of the nation's premier transplant programs, correct?
Yes, that's correct. Yeah.
What was your experience at UCLA?
So as much as I've learned from Houston, there was this component where I needed to learn more about the liver, which is my practice right now. Liver, from liver transplant standpoint, as well as the physiology and pathophysiology of liver disease, such as liver cancer and as such. So I decided to pursue additional training at UCLA, and once again, very fortunate to have another mentor by a well-renowned liver transplant surgeon, Dr. Ron Busatil. So that has been very grateful for the two mentors that I have who took me on, and I've learned a lot from both of them.
Now, you were in you mentioned liver, but it's also a solid organ transplant program. What are the other organs then as well?
So in that program, in addition to liver, we did kidneys, we did what we called multivisceral, which includes the intestine, and in some patients, they would benefit from multivisceral. That would include a liver, a pancreas, intestine transplant.
Mm-hmm. And as we look at, kidney transplant has been, around for years, but liver and pancreas and intestines, those are newer. And what is the success rate for those transplants compared to, say, a kidney transplant?
So as you had mentioned, kidney transplant is probably the first organ that has been successfully transplanted. And liver and intestine are during the latter part, because as compared, if you go back to history, the first kidney transplant was performed in the early 1900s. And it wasn't until in the 1950s to 60s when we have experimental liver transplant, and then in the 60s where the first human liver transplant is. So for liver transplant, the outcomes are very good. So we're looking at approximately 80% 5-year survival, and we have a lot of kids or babies that we transplant when they were under 6 months of age and end up growing up to in the 20s, 30s, got married, have family. So outcomes are very good for the liver. For intestine, the outcomes are not as good as liver, but they're acceptable. I would say probably the 5-year survival compared to 80% in liver is about 60 to 70%.
And how about the pancreas?
Pancreas has been around too. The outcomes for pancreas are very good as well. Typically, you would perform a pancreas together with a kidney, because these are patients who would require both kidney and pancreas because of their diabetes.
Mm-hmm. So how many years were you at UCLA?
I was at UCLA for 8 years.
8 years.
Yeah.
And then what led you to the Medical College of Wisconsin?
Well, that's an interesting question. So I was fortunate enough to be recruited after my training in UCLA to become one of Dr. Busatil's faculty. As you mentioned, it's one of the world-renowned transplant program. And when the MCW opportunity came, it almost resonated what I'd experienced as a young child. When I visited the medical college during the interview process, one thing that really resonated was there was a group of disadvantaged patients here due to their advanced comorbidities that they're not able to access the liver transplant, which is the definitive life-saving operation. At that time, I realized after 3 3 visits here, really looking at the patient population, the transplant rates, and the acuity of the patient that were transplanted here then, I really believe that there is a group that just because of their advanced comorbidities are not able to access. And a few of them who had enough resource were able to get the transplant out of state. However, there were a few or more who was not able to access that care. And so that really resonated and made me want to come here, because I thought that it is time for me to give back to the profession and the community that had given me a lot.
Now, when you mentioned comorbidities, what are the comorbidities? What are the factors that these patients were dealing with?
Yeah. So for liver patients, they're quite different from the kidney failure patients. So for kidney failure patients, we have excellent dialysis machine to keep them going, and it's not as good as a working kidney, but that should suffice for them to stay healthy and go back to work. Unfortunately, for liver, we don't have that machine, and they will start deteriorating. Wherein they're as complex as the liver is with regard to its function, that includes building proteins for our nutritional nourishment of the body. It also clears the metabolic waste or the poison in the body. It also makes bile to help us digest food, and also antibodies to prevent us from getting infected. So if you would wonder, those are just a few examples of the function of the liver. If the liver organ starts failing, you have all those systems failing. That means that patients typically are very malnourished. Their kidney function will fail, then their heart function will fail, their bone marrow function, their immunology, their body immune system will fail as well.
So it's a domino effect.
A domino effect, and to the point that, and you don't have a machine to carry that function, so they will deteriorate. They'll come sicker and sicker, that they will require ICU care. Most often, because they could not clear their poison, they'll require a respirator. They will develop renal failure. They will require dialysis machines. So they're the sickest, probably, as you could imagine, in a hospital.
Now, when you were recruited to Milwaukee, who were the people that you met with, and what were your impressions of the program as well as the city, and what surprised you?
The most surprising thing for me when I came to visit Milwaukee is the city itself. You know, it's under-advertised, which I would prefer to remain like that so that it won't get populated so much. I think that it's a wonderful city with a lot of character. Second is the people, the leadership in the community, in the medical college, the hospital at Frederick, and the Children's Hospital. I think the leadership at that time shared the same vision, that they're able to bring new change so that patients can access cutting-edge medicine without having to leave Milwaukee.
One of the things that's unique about your program is it is a program that is a collaborative venture of MCW, Frederick, Children's, and then the engagement of the Blood Center as well.
Yeah.
This is unique as programs go. What brought all these institutions together in support of one program?
I think that speaks of our practice. It's not a one-man show. So you could have a leader, but everybody works collaborative. So to take care, as I always tell them, it takes a village to take care of one single transplant patient. And so that is just a reflection of how we round every day. We have a multi-specialty, multidisciplinary specialist rounding on each patient every day. And so that's because they're quite complex, and that you require a team to take care of them throughout all phases of their care, from before transplant, during the operation, and after the operation. And so if you magnify that, I think by having those 4 institutions that you mentioned, which is the college, the adult hospital, Frederick, Children's, and the Blood Center, it collectively gets all the best and the brightest in the field, including the institution, to put this resource together.
Who were some of the people you met with when you interviewed here?
I met with, starting from the very top, will be Dr. John Raymond, Dr. Kirshner, from the MCW, Dr. Doug Evans, who's the chairman of Department of Surgery. From the hospital side, it was Kathy Jacobson, Kathy Buck, and from the children's side, it was Peggy Troy, it was Cindy Christensen then who served as the president.
When you look at transplant surgery, and especially liver transplant surgery, when you were in your training to the program today, what are some of the significant advances that have occurred?
I think there's one from the medication development to prevent rejection. I think it's been a significant change from the time I started my training, and to the point that acute rejection right now is probably at its lowest, and it's reversible. Now, if you go back, dial back even to as far as 10 years or 15 years ago, we were not in this level yet. The challenge that has remained the same since I started training is what we call the chronic rejection. So as opposed to acute rejection, which is typically reversible and with an incidence lower with the good medication we have, chronic rejection is a slow process that, short of a better word, eats up the organ. And so far we have not gained a lot of headway, in that aspect comparing 20 years ago when I started my training. The advantages in patient care definitely is much better. The reason why we're able to take care of these very sick liver patients before their transplant and get them through the operation, and then after transplant care in the ICU, to the floor, the rehab, and then, hopefully most of them will be able to walk home. And I think that speaks of the collaborative multi-specialty care. So for the pre-transplant, we work closely with not just physicians, but everybody in the practice. That includes the pharmacist, our dietitian, our physical therapist, ICU nurses, our coordinators. So that's it's all hands on deck. And then in the operating room, you're doing with the sickest patient, we partner with our anesthesiologist, who's our partner there in the operating room in getting the patient through. And then after, we have our hepatologists, our nephrologists, intensivists working with us closely. So I think that concept has changed a lot since from the time 20 years ago when I was in training. And I think that leads to only improvement of patient care.
One of the advances that's occurred in liver transplantation is the partial liver transplant, primarily for pediatric patients, where you don't have to have a donor that has died. A donor can remain living and donate part. This has really changed the field, hasn't it?
It has. It's actually started in the late 80s to early 90s, and the first live donor was from a mother donating to her child. And so when we speak about partial transplant, I think we have to go back to the unique ability of the liver organ itself. So you could divide that into 8 functional units, or what we call segments. And as long as you attach all those blood vessels in the bile duct, which includes the portal vein, hepatic artery, hepatic vein, and then the bile duct, with normal cells that should regenerate. And so the interesting about the liver is that you could remove a segment and it will grow. And so by having that unique ability, and with the earlier surgeons who have determined, the anatomy, we're able to offer more access to patient in need of transplant. And in particular, as you would imagine, the group of patients that's really disadvantaged are the small child under 5 years old, because most of our cadaveric or deceased donor are from adult, and you can't shove a big liver into a small child, which oftentimes the liver is bigger than the child. And so by having that technology or technique and specialty and expertise, we're able to offer a life-saving operation to younger kids.
Now, is the liver one of the only organs, though, that can grow and you can take a portion of it and it can grow into a whole new organ?
So from the solid organ, transplantable solid organ, yes, it is. And so to further expand on that, we could also use a deceased donor and split the organ and save 2 lives out of 1 deceased donor. So not just using the partial graft from a live donor. So in that way, we're really able to offer all the graft options or the different graft options for patients who are in need of liver transplant.
So that's a significant advance then.
It is, yes, absolutely, yeah.
What's the difference in terms of caring for children that need to have a transplant compared to an adult?
So
is the supply one of the key issues?
Supply is one of the issue, and also, if I can backtrack, my wife's a pediatric nephrologist, and she always reminds me that children are not small adults. So I've been trained very well by my wife, and so I think the attention to details, number one. The complication rates for children is definitely higher than adult because imagine we're sewing micro vessels. So the rate of that clotting is much higher than sewing a bigger blood vessel. So the room for error is definitely much narrower because say a 10 cc blood loss for an infant is a life and day, day and night for them, whereas 10 cc for an adult is nothing. So I think there's difference. Their immune system is more revved up, so they will need more medication to prevent them from rejecting. And as you go up on more immune suppression, you have to watch out for more adverse effects of medication. So it's a completely different field. Attention to details is probably 1,000,000 times more. And but despite those, I think it's one of the most satisfying field in my practice.
When we look at some of the conditions that patients have dealing with the liver cancer, hepatitis C, are these patients that would be candidates for a liver transplant?
Correct. So liver cancer, if they're not resectable, either because they don't have a good liver to keep them alive, if you resect too much, or if it's all over the liver, that the only way to get rid of the cancer is to remove the entire liver, that would be the treatment of choice for those types of cancer.
And how about hepatitis? Can a hepatitis patient get a transplant?
Yes. So both hepatitis B and C, so these are virus with that slowly eats up your liver. So for instance, for hepatitis so if you get hepatitis and it's not treated, either B or C, it's not treated, probably in about 2 decades or so, you'll end up with a cirrhotic liver. And so those patients would benefit from a liver transplant.
How about cirrhosis? Are patients with cirrhosis candidates for a transplant?
Correct. That's actually the number one indication for transplant is to have this cirrhosis, which is pretty much the very end stage of the hardening of the liver. Yeah.
Shifting to another organ is the kidney.
Yeah.
And the program here is considered one of the most successful kidney transplant programs in the nation. Why?
I think attention to these details, just like I mentioned to you, it's a collaborative effort from the surgeons, our colleague in transplant nephrology, pharmacists. I think that's very important. And second, by improving while there's no difference in outcomes in live donor or deceased donor in liver transplant, there is a big difference in the kidney transplant. So patients do better from a live donor kidney than a brain-dead kidney. Their half-life is definitely longer. And so as we increase the proportion of patients getting a live donor, definitely they'll benefit more by having a longer half-life or longevity of that organ working. The risk of rejection is definitely lower. And so they're going to be facing with less complication, from high dose of immunosuppression.
Do you have a significant population here in Milwaukee of people who are potential donors or people that step forward to donate a kidney?
So that's an ongoing effort. When I came here 5 years ago, our live donor kidney transplant populations comprise about 20 to 22% of our transplant volume. Last year, we've done great. We've achieved around 33%, so there was about a 10% increase in our live donor. And I think that is an effort and initiative that we're concentrating on. One is that they don't have to wait so long. And two, there is definitely a clear benefit in a live donor kidney transplant.
One of the challenges with donors is that race does play a factor. And one of the areas of concern has been encouraging African Americans to become donors. Is this an effort that's underway here?
It is. And nationally, the most challenging thing for us across different ethnicity or races is that the misconception that there's only one person behind the curtain deciding who gets this kidney and who gets that. Actually, I think education is number one. Educating the public to say that this is a system with federal oversight. So once you're listed in a program, your name gets into a national database. And so as donors become available, there's not a single person behind the curtain making that decision, but I would say it's a fair system in organ allocation.
One of the other organs is the pancreas.
Correct.
And MCW's Department of Surgery is renowned for its work in pancreatic cancer. Does that also impact the pancreatic transplant program here?
So the indication will be different, but so most of the patients who would need and require a pancreas transplant are typically diabetic patients. And as such, they would benefit from two organs, which is, as you know, with diabetes, it also would result in kidney failure. Others are, so often they would benefit from two organs, which is a kidney and a pancreas transplant.
And do you have a pediatric population that also requires pancreatic transplants?
Most of the pancreatic population are probably in the teens that would require pancreas. It's very uncommon for a newborn, to require that because as you could imagine, you have to weigh the risk and the benefit. With the advent of having insulin, I think the benefit of having a pancreas comparing to the risk for newborn, probably the insulin would be less of a risk than a big operation.
When you were at UCLA, you mentioned that you were also doing intestinal transplants. Is that a program that we have here?
We don't have that program yet, but that's I'm working with the Children's Hospital in studying the feasibility if we have number one the infrastructure to support that, or if we don't, what are the infrastructures we need to develop should we decide to move forward.
Getting back to the pancreas, do you work then with endocrinologists as well because of diabetes?
Correct. So work with endocrinologists and our nephrologists.
Correct. Okay. What is the population? How many people are you dealing with? How many people are on the waiting list here for kidneys, for liver, for pancreas?
So for kidneys, we have approximately around 400 to 500 patients waiting for a kidney transplant in our region here, both at Frederick and at Children's. For liver, I would say we have about 120, 130 patients waiting for liver. Kidney is very, very small. I would say around 8 to 10 patients waiting for a pancreas.
How do those numbers compare with some of the other centers nationwide?
I think so once we compare numbers with regard to how many transplants we do, how many patients on the list, it pretty much is in parallel to the population in our city. So Milwaukee would be considered a mid-sized city, And I think that's a good number for a mid-sized city, because 5 years ago, for instance, our patients on the liver transplant list is only less than 50. So growing that from less than 50 to 130 over the last 5 years has been an enormous effort. One, through the collaboration with multiple institutions. Number two, you have to have good outcomes. You gotta have good outcomes in order for patients to come here, and also for their physicians to have this, that they're pretty much trusting their patients to us.
You mentioned collaboration. Beyond the collaborators here on campus, there are organ transplant programs in Wisconsin, at the University of Wisconsin, in Aurora, St. Luke's, and then there are transplant programs to the south down in Chicago. How do you collaborate with those programs?
So most of the how we collaborate pretty much is in the regulatory. We have this organization called UNOS.
And that's the United Network for Organ Sharing.
That's correct. Yeah, that provides oversight for transplant, which is which is contracted by the federal government. So in our region, we're part of Region 7, which includes the 5 states, which includes Wisconsin, Illinois, Minnesota, North and South Dakota. So that region has representative from each transplant centers that we meet regularly and to discuss issues with organ allocation, how to improve organ allocation. So that's one way that we collaborate. Second is that 5 years ago, when I came, I started this annual solid organ transplant symposium. That, in the scientific manner, I think we could collaborate. While clinical programs compete, I think there's always room to collaborate in the science to move the field forward. And so when we started that, and I'm really proud that MCW is heading that, is we're able to, the last 5 years, invite world-renowned transplant surgeons, researchers, and physicians to be our visiting professors. That's a 2-day educational meeting where abstract scientific presentation from our region here and outside come here to present, and have those visiting professors sort of chair those sessions, and then also give their visiting professor lectures. So I think that's a very good venue to collaborate in the science in moving the field forward.
You mentioned before that transplantation decisions are not one individual, that there are many factors. UNOS is the body that helps coordinate that. How has UNOS changed over the years in some of the determinations that are made on who gets an organ and who gets priority?
So from that regional group that I mentioned to you, so there are 11 regions in the country. So there's Mole region, and then there's a national meeting that goes into that. And so we have, in the field of transplant, it's probably one of the most transparent practice in field of medicine. Even, in the early 80s, patients can track each center's outcomes with regard to survival outcomes. And now that we have the ability to surf those in websites, in UNOS websites, all programs are really accountable for their own outcomes. So having that huge database allow us to really discuss on a real-time basis where do we have, if we have to change the allocation policy, to be equitable and provide access to patient in needs. It's always a problem when the demand of for organs is so high that you don't have enough supply. And so it's a difficult decision to make what's the best policy for everybody, but there is ongoing decision. That's where UNOS comes in trying to work with us in order to serve the community.
With the advances in organ transplantation, some of the boundaries have expanded so that patients who perhaps may not have been considered in the past would. Have we now, what is the age barrier? What is the age limit? To what point do we continue to do transplants? And are there in the past, if someone had an alcoholism problem, they may not have been a candidate for liver transplant. Has that changed?
It has. So I always say that it's the physiologic age that matters, not your chronologic age. So by and large, there's no cap to the chronologic age. Uh, and I mentioned earlier, too, that in evaluating a transplant candidate, it entails the entire group to make that decision whether the patient is eligible or a good candidate to move forward with receiving an organ. Second, when you alluded to the alcoholism, there is a general mandate about what is the minimum required commitment for the patient who had history of alcohol intake for them to make it through transplant. What makes our program more unique than that is 5 years ago, we took it one step further. In our transplant program, we've developed a very good transplant mental health program. So, for example, in the common practice is you have say a social worker, either a psychologist or psychiatrist evaluate a patient's risk based on their alcohol intake in the past, and then that sort of becomes the decision whether the patient should go through or not. What we did in our program is quite unique. It's one of the few in the country. Is that we've developed a transplant mental health program, which consists of a group of specialists, which is in our program at Medical College is headed by a transplant psychologist who works closely as a team with our social worker and our addiction specialist. So rather than just be a gatekeeper, they actually develop programs in optimizing a patient's candidacy. So after providing that program and the patient still fails, then I think we could pretty much say that probably patient won't be the best candidate to get a scarce resource.
But this is a proactive program to really try to help patients become candidates.
Correct, and not only just become candidates, that program goes on even after their transplant. So I always believe that being an academic program, that we should not turn our back on our patients and our community. So say this high risk, take for instance a patient with heavy history of alcohol, was referred to us by a community physician or practitioner. I think we ought to have programs to give them the best chance to succeed. And if they don't succeed, then at least we did the part that we're supposed to do as academic programs. And but I think that allows patients to get in. Sometimes, I always believe in second chance. And sometimes some patients will get it in the first shot. Some you need to constantly. So our program is very stringent that they need to really require and meet those programs. But at least there's a program for them to get on.
MCW also does lung transplants. We had heart transplants.
Yep.
How does your program coordinate with other organ transplants?
So when I was recruited to this position, my administrative hats also cover the heart and lung transplant programs. What we've done is from the administrative organizational structure, we're one program because by federal mandate, we have to submit a lot of regulatory paperwork, documents, and I think it's to the best of the program to have one administrative structure. So that's what we have. So we interact with them on a regular basis. We have our program directors meeting, which is monthly, where we share best practices, what we need to do as a group, both adult and children. So we are integrated under one umbrella.
And we are the only children's heart transplant program in the state, I believe.
That's correct. Yep, and it's an excellent heart transplant program.
Mm-hmm. You mentioned before the intestines is an organ. Mm-hmm. What's on the horizon? What are other organs that may be organs that could be transplanted in the future?
So there's been growing interest in what we call composite tissue transplant. These are face, limbs. Again, a few centers have started doing this. So that's coming up. However, on the other hand, with the advance in biomedical technology, where you're able to um, through stem cell, that you're able to preserve some of those function, or or grow tissue, and eventually organs. That's going to be interesting to watch. Yeah.
One of the issues that has been discussed is the fact that organ transplants we do today are life-saving, whereas a face transplant, an arm transplant, is quality of life. What role do ethicists play in terms of helping determine what are the organs that should be transplanted, what is not a life-saving necessity?
Well, I think the ethicists will have to play a big role in as you alluded to, in the quality, the organs or transplant that are not considered life-saving organs. We always have to weigh balance. Say, if for limb transplant, you have to take into account immunosuppression. Rejection rate for limb transplants is very, very high. And then on the other hand, you have excellent advancement in the prosthesis. Without risk of infection, without immunosuppression. I think those are factors, and I think, let's not forget, I think the person in the middle of this should be the patient. What risk do they want to take? Where I think that impacts the success rate. If a patient does not want to take medication to prevent rejection, then maybe prosthesis will be the best option for that individual.
You hold the Mark B. Adams chair. Mark Adams was one of our pioneers in transplant surgery, and before him was Myron Kaufman.
Yeah.
When you took on this program, what was the legacy of the transplant programs? What were their contributions?
It was a big shoe to fill, shoes, both of them. I have a lot of respect for individuals who wants to push the envelope and move the field forward. And those two individuals, Dr. Kaufman and Dr. Mark Adams, are pioneers in our program. Dr. Kaufman performed the first kidney transplant in '67 here, and Dr. Mark Adams performed the first liver transplant in '83. At that time, in '83, there are only 5 or 6 centers in the U.S. That perform a liver transplant. So that both individuals have vision to move the field forward, and as well as the same as what they can do to serve our community here.
Earlier you mentioned doctors in both Houston as well as at UCLA who were your mentors. In addition to being a surgeon, you're also a teacher. And as you work with medical students, residents, with young faculty, you've had a chance to mentor them. Who are some of the people that you've mentored whose careers have gone on to work in the transplant area?
So for the residents that I work on, I would say around 20% ended up going to transplant. And we also have fellowship programs. And a lot of them are in good academic positions that are going to be the future leaders in our field.
You've had an opportunity to help pioneer some surgical procedures as well as do some research. As you look at the contributions you've been able to make, what are the things that you take pride in?
I think the number one would be the passion I have in achieving excellent outcomes for our patients. I think being there for them, doing it for the right reason, is the most important thing for me. I should be able to look at my kids and my wife's eyes every night that I did everything I could. I think that's one more most important thing that I thought that I would be able to teach the trainees. From the scientific, I think I'm really fortunate to learn from the best mentors that I have that allow me not just to do what they're doing, but there's enough that I could say I could push the envelope a little bit more and not give up the safety of the patient and still achieve what I thought would be the best for the patients.
What do you think are the advances that have occurred in the transplant program in the time that you've been here?
I think clinically, we are doing an excellent job in taking care of what I consider disadvantaged group in the past. We're able to take the sickest patient, and in the past they would not have the access for a cutting-edge transplant. Now we have excellent outcomes. The last few years, if we look back, in Region 7, majority of our liver patients, a great proportion are those sickest that other regions probably won't even consider. And we're, even with that, we have excellent outcomes. Second, I think, is the research I'm working on, is how do we, as we know, the major problem we have is we don't have enough organs to go around. Only quarter or a third of the patient on the list will get a transplant. And so how do we convert those organs that today are not usable to something that we could use? And so I have developed this solution that's under patent review right now in trying to improve the function so we could convert what is untransplantable organ today, which is for liver, that we'll be able to transplant in the future.
That's exciting.
It is exciting. Yes. Yeah.
Well, I want to thank you. I want to thank you, Dr. Hogg. This has been very interesting.
My pleasure, and thank you for having me here.